Professor Jayanti ma'am, and other senior faculty members. This is our first edition of clinics for May 2021. And Professor Vinay Kumar is well known to you. He was a former Professor and Head of Department of Gastroenterology, Government Medical College, Tirunelveli. He was the Vice Dean of Government Medical College, Tirunelveli, and the Dean of Travancore University Medical College. Briefly, he was at Chennai also SRMC as Professor of Hepatology as well. So, and he has taken one clinics for us earlier, and it was well received by all the students. And Professor Vinay Kumar will be taking two cases today. And the students are Vivek, Snija, Kushan, and Cyril. The person on standby are Santosh and Dr. Kurula. And as the usual house rules, everybody other than the presenter and the teacher, the audio and video should be off. No chat box comments in between until the faculty ask you to put any specific comments. Myself and Jayanti ma'am will be in the background, occasionally as internal examiners, maybe helping you out. Okay. With these words, I request Professor Vinay Kumar to start his session.
They can ask questions on the chat box, no answers.
No, the chat box only questions, but no answers.
No answers, no comments.
Okay, Professor Vinay Kumar, please.
Okay. Yeah, good evening, Professor. Dear Professor Varghese Thomas, Jayanti ma'am, Dr. Sojan, the faculty members, colleagues, and dear residents. So today I will take you through two of the cases, and mostly in the OSCE style. And the objectivity can be maintained in the online platform. Before we start, I would like to share some of my comments about the exams to the exam-going students. Exam has to be taken a bit seriously. You need to prepare and perform. That's very important, And in the examination, there can be two types of questions. One type will be very straightforward and simple questions. And about 80% of the questions will be of that category. And then, of course, there can be some difficult questions also. So which do you think is very important? Obviously, what is more important is the simple, straightforward questions. Because these questions would decide, whether you get through or not. And the difficult questions, it'll earn you good marks, but they are not deciders. Even if you don't answer a difficult question, well, it will not affect your pass possibility. So I think that's very important. So why I find why the student, what are the problems of the students during the examination? Well, they don't answer properly even the simple questions because of two reasons. That's what I believe. Number one, they don't listen to the question. They don't understand the question properly. So their focus and listening is a problem. And the second, in fact, they know the answer, but they are not able to place it across properly. So that's where you need to focus, that's very important. You need to focus, number one, and number two, well, there should be some sort of preparation also. Even if you know the answer, you should know how to place it across. And then, of course, there may be questions that you do not know. And there will be really difficult questions, probably it won't actually really matter as well. So I think with this, my general in the tips for the examination, I would like to take you to the first case. These are all the cases are real cases in the ward right now. One is actually discharged, one of the patients is even now there in the ward. The first case, I'll share my screen right now. Is it okay now? Is it okay?
No, it's something different.
Is it different now? Is
it
okay?
Okay, now it's okay.
Okay. Probably it may take some time, that's all. Yeah, the first case, in fact, I'm going to share with you, in fact, is a sort of case, which I have seen a few times in the examination as a short case, and then one or two times, during the wardens also. And I found that they can not actually perform well. So I found a case in the ward. So I thought I would just select this case. So I just asked the brief questions to Dr. Vivek and Dr. Snija. Okay, and then I just have a brief pause. And after getting the results, I will also give you the expected results, expected answers. So you may be able to, make an opinion about that. And then others may be having some comments, the questions, etc., which probably you can hold back for the end, that you can have a general sort of discussion for about 10 minutes towards the end of the case. So now just listen. This is the case. It's a 20-year-old female presenting with anorexia, abdominal bloating, constipation, and weight loss of 1 year duration. There is no history of fever, joint pain, palpitation, or leg edema. And she has no menstruation since about 7 months. So I think, Vivek, what would be your differential diagnosis like? It need just be 1, 2, 3, 4, etc. That's all. What is required? Yeah.
Yes, sir. So in this case, sir, my differential diagnosis will
No. 1, 2, 3, 4. That's all what is required. So in the best interest of time.
Yes, sir. One is hypothyroidism. Second will be another. I will like to consider GI pathology. So colorectal cancer.
I can read again, presenting with anorexia, abdominal bloating, constipation, and weight loss of 1 year duration.
These are only two.
Okay, so you mentioned about hypothyroidism and then colorectal cancer.
There's someone backing up. Can anyone backing up any differentials?
Yeah, you can go for Sinija, then Dr. Sinija.
Yeah,
what would be your difference?
I would like to consider possibility of chronic infection like tuberculosis.
Yeah, tuberculosis, yeah. Then.
And IBD. Though patient doesn't have any abdominal pain, Crohn's is a possibility.
Okay.
And eating disorder.
Yeah.
Anorexia nervosa.
So I think, I have got my differential diagnosis here. It's a type 1 diabetes, then which is not well controlled. Probably she may not be knowing about that. And then conditions like thyrotoxicosis, not hypothyroid. Probably I think that, thyrotoxicosis may be a better answer. And then Addison's disease, then Addison's disease are there. Okay, so if you have not come across in your practice, it's a condition there. And tuberculosis, especially biliary tuberculosis, where the patient may not be having much symptoms, including fever. Tuberculosis is called phthisis, because it's a shrinking process, HIV infection probably you need to mention, and hematological malignancies like leukemia, etc. So what I want to emphasize is that we should have a general screen. Well, you cannot just jump back to the GIT condition. And then of course there are GI disorders also. And then I'll just mention the GI disorders of my differential diagnosis, As you have rightly pointed out, anorexia nervosa is a diagnosis, And then there can be malabsorption syndromes, can the malabsorption syndromes present without diarrhea? So that is the question. Here the patient did not have any diarrhea. So the point in fact is that, the diseases involved in the proximal small intestine, they can present without any diarrhea, as in the case of celiac disease, and the bacterial overdose syndromes, jejunal diverticulosis, can have extensive jejunal diverticulosis, jejunal Crohn's, again, rightly pointed, etc. So I think there are some conditions, which you should have the differential diagnosis in the mind. Okay, so I think anorexia nervosa, in fact, is a diagnosis mainly from the history, less from the general examination. We just look at the American Psychiatry Association, is a criteria, etc. It's mainly from the history. Okay, so just tell me 5 leading questions you may ask in anorexia nervosa, which will clinch your diagnosis. Okay, again, you can go back to Vivek first and then to Srija.
Yes, sir. First, I will ask history of reduced food intake. Second will be use of any medicines, chronic use like laxatives or diuretics to reduce the weight. Any associated psychiatric illness like depression or anxiety, and uh, history of chronic weight loss.
Okay, Srija, can you answer now?
Yes, there is a
You can have your independent answer, or probably you can supplement what is given to you. Yeah, this was earlier. Yeah.
A patient can have the perception of body dysmorphism. Even though patient is very lean, thin, patient might perceive herself as
louder, snatch, louder.
Patient may have the feeling of altered perception of appearance of herself, and she will deny that she is restricting food intake. She won't approach for a consultation in view of the decreased food intake or loss of weight. And there can be the history of abuse in childhood or in the family. And,
okay. So I think, well, you have given some very, very important points, but not in the form of questions, In the examination, when you examine the patient, you need to ask relevant questions, But then I agree with that. So I think the concept of body image, what is the concept of body image, that you should be able to ask. And you should be asking for the binge eating disorder, eating habits, even in the case of anorexia nervosa, there can be binge eating, you ask for that. And then the purging behaviors, you actually mentioned about that. And then the stimulant abuse, and then suicidal attempts also. Basically, this is a psychiatry, it's a mental health disease. It's a mental health disease, and you need to ask for suicidal attempts. Our patient did have suicidal tendency. Okay, so what are the purging behaviors you'll be asking for? Purging behavior. Vivek, what is the purging behavior you'll be asking for?
Purging behaviors are after either after a large intake of food or even without a large intake of food. Usually, patient used to take more of laxatives laxatives as well as emetics to purge the food intake outside. And they can also take diuretics to reduce the weight by basically losing body water. These are.
I think that's excellent, Yeah. There may be purging behaviors, forced vomiting, They may induce vomiting by different mechanisms. And then laxatives, as you suggested, self-edema may be there. And then diuretic abuse also. So I think that's it. And there are some non-purging behaviors also, which we need to explore. Srija, can you just tell me about that? Non-purging behavior.
Excessive exercises, which may damage herself, which is beyond her comfort level, and there can be excess use of insulins more than the required dose.
Okay, I think that's very good, There are restrictive eating patterns, They go to fasting, maybe religious or other things, They skip the meals. They avoid the nutrient foods, they always look at the nutritional value. And they'll be using stimulant abuse, like caffeine, thyroxine, cocaine, ephedrine, and other things and all. And then, as you really pointed out, excessive and inappropriate physical activities like, say, skipping in the night, etc., etc. So I think you need to explore those things, And now I will just show you some of the pictures here, Just look at the pictures very carefully, and what you see really in the general examination.
There is
okay.
Thinning of muscular.
Yeah. So I think, well, what did you see? What did you see in the general examination?
Loss of
subcutaneous. A few points which you may just see, Actually, you'll be looking for these things, and then you find. Yeah.
Describe the
Before
box
some-
build, describe the box build, the BMI, what are the things that you're looking
Patient is cachexic. Yes, sir. Patient is cachexic
Yeah.
with BMI of
Yeah.
less than mostly 18.5.
Yeah, cachexia, sure. You can see these, you can see the ribs, etc. there, Okay, yeah, cachexic. The subcutaneous part is not at all there. No, Srija, can you find something else?
Lanuga hairs
Yeah,
and hyperpigmented knuckles.
hyperpigmented knuckles, yeah. So I think I will just, the patient is, in spite of, the cachexia, the patient is alert and anxious. Okay, his patient is not very apathic and all. And the cachexia, of course, is you said, and the patient got a prominent parotid, and the lanugo here she mentioned, What is this? What is this sign? What do you find there? Srija, can you find something there? What is that really? It's not the indented knuckle there, but then something else.
Due to chronic induction of vomiting by...
Yeah, what is that? Yeah, you can find some excoriations, there, and there also. Excoriations are there. What is called? There are, in fact, very few signs for this condition, which is pretty. This is called, Russell's sign. Okay, and then, you said this as lanugo here because, there can be lanugo here in anorexia nervosa. But I want to find out that, this is lanugo here and therefore it is anorexia nervosa. So why did you say this is lanugo here? I know that many of the people, they make the diagnosis of lanugo is correct also because it is anorexia. You make the diagnosis of anorexia nervosa and then there will be a hair, you call it lanugo hair. The reverse I want to. Why did you say it's a lanugo hair? What are the types of hair? It's a vellus hair, which covers the entire body. There will be terminal hair, which you may find on the scalp, beard, and then the armpit, etc., which is hormone dependent and stout. And then there are lanugo hair also. Okay, this lanugo hair actually, this is the hair you see in the utero or the fetus, and then after a few days of birth, it will disappear. It will just fall off, These are thin, non-pigmented, non-hormone dependent, very flimsy hairs in the infants. The importance is that, you don't see it in the adult. If you see it in the adult, mostly it is anorexia nervosa. So I think you need to make a diagnosis of the lanugo hair and then make the diagnosis of anorexia nervosa rather than making the diagnosis of anorexia nervosa and then looking for the lanugo hair. Okay? And the differential diagnosis of lanugo hair in adults. If you find in young adult, it is anorexia nervosa. And old adults, it is malignancies like lung cancer, prostatic cancer, and ovarian cancer. So that's the importance of lanugo hair. And you need to make a diagnosis of lanugo hair. And just the outline, the principles of treatment here. Can you do it? Just the principles only, not that.
Yes,
the broad principle.
Principle of treatment is, sir, first is weight gain, achievement of normal weight. Second is establishment of a normal dietary pattern. And psychiatric counseling and reassurance. And family support.
I think you have well said that, because basically you should know that, it's a mental health disorder. And you need to have a psychiatric consultation because one of the complications, the common complication is actually suicide. So you need to address the psychiatric, the aspect of that, and there should be proper psychiatric consultation. And then you have to correct the metabolic problem, nutritional management, and the institutional therapy. The patient has certain suicidal tendency. You said very well. There are some challenges in the nutritional management. Can you just highlight the challenges, Snija? You expect some challenges here.
Especially when the patient with a
very
low body mass index, when we start feeding, there is high chance of overfeeding and there can be hypophosphatemia and patient can develop cardiac issues, and due to excess fluid overload, there can be pulmonary edema and very high blood sugars. These metabolic issues can occur with starting feeding in patients with anorexia nervosa.
Yeah, you said that, there can be some feeding problems. Feeding may not be that very easy, because there's always this avoidance behavior is there. So you need to go for parenteral feeds first, assisted enteral feeds and supervised oral feeds, etc. So feeding is a big challenge for in these cases, And the second, probably, though you did not actually tell the word, you meant the refeeding syndrome. Okay, so I think again I will ask to Snija, what is this refeeding syndrome? You just tell me very briefly about that, definition, pathogenesis, clinical features, etc. Very brief.
When we start feeding,
you said that, just organize. Yeah.
Because of the high blood sugars, excess insulin will be secreted. That will shift the intracellular that will shift the phosphate from the intravascular to the intracellular level. So there would be an apparent hyperphosphatemia, which can affect the myocardium, and patient can go for arrhythmias, and sudden cardiac death can occur.
Yeah. So I think, well, more or less correct, I think, well, but then refeeding syndrome, you should be knowing that, is in your theory as well. Yeah, because of the, there's a phosphate deficiency and potassium deficiency, magnesium deficiency. And when the calories are given, when it's converted to energy, you need a phosphate. You find a severe phosphate deficiency. And related to that, you find, then drowsiness, even seizures. And then the potassium is, what is driven inside the cell, in fact, is potassium, Okay, and then hypokalemia, and you find serious features of hypokalemia. So I think you need to take care of that, So I think it's a theory question for you. And suppose this patient has got a severe abdominal pain and vomiting. What will be your differential diagnosis? In fact, in the ward, this patient developed severe abdominal pain and vomiting when we start the feeding. So what will be your differential diagnosis there? Vivek?
Sir, can be acute pancreatitis diagnosis. This patient.
Because there are some defined
problems
you can have,
Mesenteric ischemia, second, vascular ischemia, basically.
Yeah. And Srija, can you just supplement that,
Certain thin individuals, they are prone for SMA syndrome.
Yeah, you said some point, it's people they can go for acute gastric dilatation and gastric wall loss. And this Wilkie syndrome. What is this Wilkie syndrome? Vivek?
I don't know.
Yeah. Srija?
I don't know, sir.
You said it. That is superior mesenteric syndrome.
Yes, sir.
Yeah, that's it. You're correct. The answer is correct. But then you are not identifying it with Wilkie syndrome. Okay. And these people can have sudden death, Why should they have sudden death? They can commit suicide, But then otherwise, what is the cause of sudden death?
Electrolyte imbalance, hyperkalemia, hyponatremia. Sir, electrolyte imbalance can cause sudden death.
It's not during the refeeding syndrome, Even otherwise, the patient runs this particular risk. I'm not referring to refeeding syndrome right now. Srija?
Very sure of, sir.
Yeah, these people, they can have ventricular arrhythmia because of QTC prolongation. Okay, you call it what that? What syndrome? Torsa? It's written there.
Torsades de pointes.
Yeah, torsades de pointes. It's actually a French word, How do you pronounce that? Yeah, the S in fact is silent. Yeah. Torsades the points. Okay. S in fact is silent. It's a French word. Okay. And then it can be aggravated because of hypokalemia, refeeding syndrome, and antipsychotic that you give. So you should be very careful to choose these antipsychotics, so there's a problem. So I think, well, we'll coming to the end of the case there, Well, eating disorders, are they functional bowel diseases? In fact, eating disorders, are they classified as functional bowel disorders?
No, sir.
Are they?
No, sir.
No, sir.
Yeah, they are really considered as a mental health disorder. Okay, so actually, criteria will be diagnostic and statistical manual of mental disorder, just like our, this IBS criteria going up. They have considered DSM-5 criteria are there. So you can just tell me, how many eating disorders are there? A number you can say, and then you can try to say few. According to you, what will be the number like Vivek? How many numbers are there? Sinija, how many numbers are there?
Anorexia,
How many?
bulimia, and unclassified.
Yeah, so I think, just go through your serious injury, there are 8 disorders, and then it'll be looking nice if you can just, say at least about 4 or 5. Okay, and then I'll just wind up here, there can be advanced level questions also, like, what is about long COVID and what it has to do with eating disorders, a lot of papers are now coming up in the COVID era. And gut microbiota and eating disorder, a lot of papers are there for that. And the gut and adipose tissue, hormones in eating disorders, some landmark studies are there, papers and reports are there. So I think, this can come up for advanced questions also. I think with that, I just wind up this particular case, and then we can hear the questions, comments of others also. So Professor Varghese Thomas, Professor Jayanti.
Evaluate this patient, investigations, Dr. Vivek.
Yes. Ma'am, I will do a complete blood count with peripheral smear, then liver function test.
The nutritional status, and you will do the FRAME T-score, and you do the sarcopenia index and all that. Nutritional assessment, how do you do the nutritional assessment?
Yes, ma'am. That I will go for mid-arm circumference measurement, then hand dynamometer. Based on CT abdomen, I can calculate whether sarcopenia is there or not, based on SWAS index.
You have to do a nutritional assessment then.
And subjective global assessment, I will assess the rating, whether A, B, or C.
Then what will be your investigation, level of investigation? 1, 2, 3.
First level, I will go for routine investigations like complete blood count, liver function tests, renal function test, including.
Then is going to help you with, that's what you need. Investigations are going to help you. So what investigations would you do?
Ma'am, you are less audible.
You think the patient will have fatty liver?
Yes, ma'am. Ultrasound abdomen I will do along with serum lipid profile and HbA1c and fasting and postprandial blood sugar.
So therefore you should know how you would investigate, including you have to know hypothyroid state and all the other conditions as well that were discussed by Sir. And then how do you get to the nutritional requirement and its management? How do you tell the patient to have what type of diet and how should she move forward?
Yes,
apart from the counseling.
Yes, so nutrition requirement I will calculate based on patient's ideal body weight and the difference of the body weight he or she is supposed to gain, and based on that dietary advice is given based on calorie requirement according to body weight and protein requirement.
I agree, but how would you ask the patient? You'd ask them to take small feeds frequently, or you'd ask them to take large feeds, or be carbohydrate?
Small frequent feeds, carbohydrate and balance in carbohydrate and protein. And
see, you have to tell in the exam. They ask, how would you ask the patient to take a diet? So I think that is very important. That you should know how you would supplement, what vitamins you would supplement. How would you take care of the phosphate deficiency? All these things you have to address. So I think this is one good case for you to write up the diet protocol that you would follow for management of this patient. Yeah, assessment, nutrition assessment, and the diet. I mean, they will ask, they ask how many calories is one roti? how many calories is there in one egg? In a small cup of meat or fish, how much of calories and protein would you supplement? All these questions are asked. And how do you supplement the vitamins in this patient? So this is one good case where you can write up. So for people, I always advise those who are down south, see that you know an average diet of a person from Andhra, Kerala, and Karnataka, and Tamil Nadu. That's all 4 states this side. And an average North Indian diet. So that will tell you exactly how much you should take for a given calorie. That's easy to calculate. It will be a fast calculation. Once you know the basic diet constituents of a particular person from a given state, say northeast, north, south, and somewhere around Maharashtra. That's it. Okay, those are my comments.
Yeah. So I think the nutrition management is not that easy, You need to involve a dietitian. You need to find out the calories, For example, this particular patient, when the patient came in, her body mass index was 14. That means that the patient requires a partial parental nutrition initially. And then you give the dietary advice, the patient will not actually go for that. We need to supervise that, And then probably this will be followed by tube feeding. We need to go for that, And then when the patient compliance increases, and then probably you have to go for your oral diet. Okay, how to make a diagnosis of this anorexia nervosa? There are 3 points in the American Psychiatry Association criteria, First of all, we have said is actually distorted body image and restrictive behavior and the fear of actually gaining weight in spite of being thin. Okay, all these criteria have to be met with, And when you meet with all the criteria, well, you may be able to make the diagnosis of anorexia nervosa and eating disorder with something like more than 90% specificity. So that's why you need to know how to ask questions, in this particular patient. And as Madam suggested, these patients will be severely malnourished, and you need to find out the nutritional problems of the patient, which they will be having very many. And your duty will be to supplement and correct those nutrition, and the other thing will be left to the psychiatrist.
How will you differentiate bulimia from anorexia nervosa, Shrija?
In bulimia, patient will be having binge eating.
So what will be the difference?
It will be intermittent. Patient may be obese or normal in the body habitus. In bulimia, in anorexia, patient will be anorexic.
So what are other differences between the two? Both all are eating disorders, no?
Yes, ma'am. It would be intermittent in case of bulimia. Patient can go for binge eating followed by
what will be the intention? What will be the psychiatric? What will be the intention of a person with bulimia versus anorexia nervosa? What will be the intention of the patient wants to gain weight or lose weight versus a person with anorexia nervosa? Are they both with the same intention that they should lose weight?
In bulimia, patient, it would be a stress relieving. It can be a stress relieving or to reduce weight, or some middle-aged females, they might feel that they are becoming so aged and they might apply some restrictions.
Who is that celebrity who is no more, who was supposed to have this bulimia nervosa?
Diana, Princess Diana.
Yeah, correct.
Okay.
I think we'll discuss all points brought out. I think in the history, the nutrition part, how much the calorie deficiency the patient is on, and whether any restrictive type of food eating. That's another important thing Professor Vinayamar said. That is special type of food they avoid and they take like that. And then on physical examination, apart from this cachexia, you have to also look for all features of nutritional deficiency, vitamin deficiency, etc., and also do tests which will show you that there is loss of subcutaneous fat as well as muscle. Okay, and the differential diagnosis which you initially thought like Addison disease, thyroid, etc., has to be also kept in mind when you do physical examination and present the case. And in the investigation also you have to think of these diseases and plan out investigation like that. Okay, so it's a very good case, Professor Vinay Kumar.
Okay. So I think shall we move to second case then,
Yeah, definitely.
Okay. So I think so I think well done, Vivek and Srija. Okay. Both are appearing for the exams. Good luck for you. I think you've done well, I think, well, this is okay, for both, it's okay. And then the other things he'll be asking questions to you, and probably you need to listen properly, and then you need to answer the questions also. Okay. Yeah. So I think, we'll take up the second case with Dr. Kushan and Dr. Cyril. Are you ready?
Yes, sir. Yes, sir. Good evening, sir. Good evening, ma'am.
Okay. Dr. Kushan is there, and then Dr.
Cyril, are you there? Dr. Cyril?
Yes, sir. I'm there.
Okay, you are there. Okay, fine.
Okay, yeah. So I will just go to the second case, Yeah. So, yeah, the second case will be, it's the case that you see every day in your clinical practice, and you may be having similar cases right now in your ward also. So this is a 65-year-old female who presented with a shortness of breath of 6 weeks duration. This is mainly exertional shortness of breath. It is not associated with any cough, chest pain, palpitation, and our GI connection comes, here. She was diagnosed with chronic liver disease 1 year ago when she presented with abdominal distension, leg edema. That was 1 year ago. Okay, and diagnosed to have ascites, and she was treated with diuretics and paracentesis twice. And our patient currently is on diuretics and non-leg edema, only mild abdominal distension. OGD at the time showed that he had small esophageal viruses. EVL was not done. The patient was put on propranolol 3 times, 20 million 3 times daily. Okay, and so that is the case. And he's a diabetic for 20 years. And he's on insulin and is moderately controlled there. And the patient is also on treatment for hypertension and dyslipidemia. There's an important family history is also there. Father died of cirrhosis liver, and she used to take alcohol. And elder brother also died of end-stage liver disease a few years ago, and then he also used to take alcohol. Okay, so that is the case now. And my question to you is that, what additional questions will you ask for her dyspnea?
Sir, I would like to ask whether there is any history of paroxysmal nocturnal dyspnea or any orthopnea or platypnea, sir.
Okay, yeah, okay. Yeah, so I think we need to ask for history of melena, because in cirrhosis liver, the shortness of breath may be because of anemia, and the patient will be having giddiness and syncopabilities also. So that you have to ask for. Okay, that probably is a very common scenario. And the platypnea, but well said, you need to go for that, and paroxysmal nocturnal dyspnea. And exertional dyspnea. This patient has got exertional dyspnea, how much, etc. And also, this patient is on propranolol, you need to ask for wheezing. So I think that would probably complete that. So I told you the straightforward questions, you should be correct in your answer. You should be complete in your answer. Okay, so these are all simple questions asked. Then I expect, correct answers and complete answers also. So look at melena, look at these. Okay, so I have already given that the patient is taking propranolol. So I think, to cover anemia, hepatopulmonary syndrome, portopulmonary hypertension, hepatic hydrothorax, and side effects of beta blockers. I think that is the intention, and with that, you need to ask the question. So I want all the questions for all these differential diagnoses. Okay? Yes. So, but you'll be satisfied that, you have said the correct answer. But then it should be complete. So this is the problem with straightforward questions. Okay? Completion is expected there. Okay? So, I think, what is the stage of cirrhosis liver? Dr. How would you stage the cirrhosis here?
She has ascites. So the presence of ascites, it's stage 3, sir. Varices also.
It is stage 3.
So,
So now the question will be, how will you stage the disease, cirrhosis liver?
Stage 1
Because the
is
confusion there. Okay, yeah. What is stage 1? This is actually European study of liver disease, classification. Stage 1 is?
Stage 1 is the presence of no ascites and no varices. Stage 2 is presence of varices and no ascites. Stage 3 is presence of ascites with
then what is stage 4 then? Is there a stage 4?
Bleeding.
Stage 5? Yeah, question. What's your comment on that? Because
yes,
it's again straightforward questions. I'm repeating.
Yes,
in the previous case, difficult questions. But then here it's straightforward, complete answers. Yeah.
Yes, sir. Sir, there are six stages of cirrhosis, sir. So in the stage 1, the liver stiffness, the LSM is more than 15, but there is no clinically significant portal hypertension, sir. In stage 2, there is clinically significant portal hypertension, but there is no varices. In stage 3, there is presence of varices. Stage 4 is bleeding of varices.
Kushan, this is not exactly what I meant. This is after investigation. The other one is actually simple clinical staging. Okay, I'm aware of that. Well, you are going the correct direction. But then
the staging of liver disease. Yeah, that's what is
asked. Yeah. Staging. The other, you're correct. When you have the investigations, you can classify that way.
Okay.
Stage 1,
you mean compensated
without any varices, without any ascites. Stage 2, you will have varices. Stage 3, ascites, and stage 4, variceal bleeding. Okay, that's all. Okay, yeah. So this patient has got stage 3. And now one more question. Now the patient has no ascites. What will be the stage like?
Stage 2, sir.
No, it remains 2? To be stage 3. No. Even if the patient had ascites, then actually it disappeared because of your diuretic therapy, even then the stage will remain as stage 3. Why? Because, that, yeah. There is the next question. What is the prognosis like? This is the importance of staging.
Yes, sir. Sir, once the ascites has developed, sir, so the 5-year survival is 50%, sir.
Yeah. So I think, yeah, that is it. In the case of stage 3, the 5-year survival is about 50 to 60%, or the mean survival may be about 2 to 3 years only. Okay. And suppose you treat the patient, make the patient ascites free, what is the prognosis? It's the same. It is the same. Okay. So that's why, even if it is going to be ascites free after your treatment, the stage will not change. Okay. What could be the etiology of cirrhosis here?
Sir,
in this particular patient. Yeah.
Autoimmune, 1. 2.
Autoimmune, yeah, autoimmune, yeah. 2.
2. Chronic hepatitis C.
Okay.
Or I'll need to know the BMI, whether there is a MAFLD or a NAFLD. She's a diabetic, so likely to be having NAFLD. MAFLD, sir. MAF.
Yeah.
So I'll place that above viral hepatitis. So the autoimmune, then MAFLD, then I'll think about chronic.
Okay. Yeah. Now I have to ask another question. How do you diagnose MAFLD? Apostle criteria. 2020.
Yes, ma'am. So for the diagnosis of MAFLD, there should be the presence of metabolic syndrome, and for the presence of metabolic syndrome, we need 5 criteria. So
that's okay. Understood. Okay. Yeah, with the metabolic syndrome.
Yes, sir. Along with that, there should be more than 5% steatosis in the hepatocyte, sir.
Okay, yeah. So I think here, this patient is a diabetic, he has got hypertension. Okay, yeah. So if you just look at the metabolic syndrome, with the presence of hypertension, diabetes, you make the diagnosis of MAFLD, if you just look at the criteria. Okay, if the patient has got a fatty liver. And then this patient has got a, can you consider alcohol here? Father died of alcohol use, brother died of alcohol use. And you need to consider alcohol also, because, the alcohol intake in female is on the rise in India as per this alcohol data, statistics. Okay? And then you need to talk about hepatitis B virus, which is more familiar, is hepatitis B. So I think here you have got the point, the metabolic syndrome parameters are there. The family history is also there. Okay, so these 2 points you need to consider and then make the differential diagnosis. Okay, and then you can also look for conditions like HCV, autoimmune, and genetics. Okay, so on the left side, the panel, in fact, is very strong. You need to make diagnosis. Okay, so these are the problems with the straightforward cases. There we need a completion there. Okay, tidbit answers will not suffice, unlike in the other case, the previous case. Okay, so I think in the examination, the patient is moderate build and nourishment, well-oriented, not anemic, not jaundice. I listen to it properly. Or you can read it. Okay.
Yes,
so you can read probably improve your attention span. Yeah.
In the general examination, the patient is moderately built and nourished. She's well oriented, not anemic. There is no jaundice. There is mild pigmentation of the face, mainly in the forehead. The tongue and the mouth are normal, and there is no flapping tremor. There is no pedal edema.
Okay. Yeah. Yeah. So I think that's the pulse like 68. Why
the pulse rate is 68.
Yeah. Why so?
So propranolol, she's on propranolol 20 milligram TDS. Sir.
Yeah.
BP is 130/90 and weight is 72 per kg. Height is 160 centimeters. Sir.
Okay. Yeah. So now the question is, any other relevant finding to look for here?
So in the general examination, I'll also look for other signs of stigmata of chronic liver disease. Sir.
No, I think your question, in fact, is this is the case of cirrhosis liver. What is the question here? What is the problem? What is the problem of this cirrhotic patient? The problem of this, I know that. See, finally, your answer cannot be, diagnosis cannot be cirrhosis liver. I told you the patient has got cirrhosis liver.
Sir. Sir, we have to look for the auscultatory findings also, because we were thinking of hepatic hydrothorax.
I think, general examination.
Sir, the respiratory rate and the oxygen saturation and the JVP. Yeah. So I think, that's well said. That's what you are actually you have to look for here. You need to look for clubbing and cyanosis. For what? Kushan, for what? Yeah. She has got clubbing and cyanosis. Your diagnosis will be? Sir, hepatopulmonary syndrome, sir. HPS, yeah. This patient has got a plaque-apnea. Your diagnosis is? Sir, hepatopulmonary syndrome, sir. Okay. He has got elevated jugulars, and you need to check for these... Photopulmonary hypertension, sir. Oxygen saturation also. I think, you need to cover these aspects in general examination, because your patient has got exertional dyspnea. Okay? Yes, sir. Okay. Yeah. Yeah, now, what is the BMI like? Cyril, can you calculate the BMI here? You take your mobile and calculate that and tell me, please.
Kushan, also you can try that right now. You calculate that.
Yes, sir.
I'll give you 1 minute for that. Be very fast.
So it's 28.12, sir.
7.6.
You did not give any allowance for ascites there.
So it is. Oh,
Yeah.
Corrected
That's the
BMI.
problem.
Corrected BMI.
Yeah, corrected BMI. So I think, you need to. So I think tell me about the corrected BMI.
yes. So sir, it is 5% for mild ascites, 10% for moderate ascites, and 15% for massive ascites, and 5% extra for pedal edema, sir.
Yeah, but then you need to apply that here also. Okay. So if you done it properly, then probably you will be scoring more marks. Okay. Yeah. So I think, just to read out this, please. Yeah.
So the abdominal
Will you please
examination is suggestive of mild distension, generalized distension. There is no veins. There is a small umbilical hernia, and the liver is not enlarged, but it is firm. It is irregular. It is not tender. Spleen is 2 centimeters below the costal margin, and shifting dullness is present. And bowel sounds are normal. There is no bruit.
Okay. So my question is, what is CTP score like, and what is the child class like? Okay, I think Cyril can. Yes. You calculate the BMI. Cyril, you'll be able to give the answer here, please. What is the CT? Both you can try it.
Sir, I would like the bilirubin, the INR level also, sir.
No, I think you need to calculate with what is available here. Can you calculate? Kushan, can you do it? If you are doing it routinely, you should be able to.
So probably she's B8 or B9, sir.
It'll be
9, sir.
Sir, B9 probably, sir.
It may be 7 or 8 be the correct answer. Okay. Why do you say it's 9? Who said 9? Sorry.
8 to 9, sir.
Why do you say it is 9? Just got aside is mild, so it will be scoring 1. Okay. So it becomes 6. And then if it is aside is, album, you expect to be on the lower side, so it becomes 7. Okay. And then we don't have any evidence otherwise. No encephalopathy, so he will not score anything there. So it's only a question of INR prolongation. Okay.
Yes, sir.
So if it is prolonged, I don't expect to be severely prolonged here. To be normal or mildly prolonged. Okay. So it becomes 7 or 8.
Yes, sir.
Is it not?
Yes.
Yeah. So what class it would become?
Sir,
Child classes? Classes?
Yes, sir.
Class B, sir.
B. And I think, so I want further clarification. So here, Cyril, what is A?
6 to 8, sir. A.
6 to 8 is not A. That's not correct. Kushan.
Yes,
What
sir.
is
Sir, up to 6 is A. Sir, 7 to 9 is B, and more than 10 is C, sir.
That's correct. That's correct. Again, the problems with the straight questions, Okay. Yeah, we want complete answers here and correct answers. Okay. Here, we will not want any sort of, wrong answers. Okay. So the first, the case, I expect, I accept quite a lot of, the lacunae. But in the second case, I don't expect. Okay. So that's the difference between the first case and the second case. The questions are very simple there. Okay. Examination of other relevant systems. Okay. What are the other clinical signs of HP? Now we are going for other relevant system examination. What are the clinical signs of HPS here? Systemic examination. Sorry.
Multiple telangiectasias on the upper. You can have
Telangiectasia where?
on the upper.
Where?
Upper trunk, sir.
Telangiectasia in the upper trunk. Okay. Yeah. Kushan.
Yes, sir. The patient he will have platypnea. So whenever the patient is getting up, there will be decrease in the.
That is covered. That is covered in the general examination. I am asking for other relevant system examination. Yeah, nothing in the chest. Okay. So type 2 is there. There can be arteriovenous communications, but then it is not actually severe enough to produce any BROE. BROE is highly exceptional there. So I think you need to make the diagnosis from the general examination. It's not from the systemic examination. And what are the clinical signs for portopulmonary hypertension?
Sir, the P2 will be loud, sir.
Yeah.
And the JVP will be elevated.
Yeah. Okay, yeah. So I think this is expected correct answer, JVP prominent with a prominent A wave and left parasternal heave and a loud P2, a systolic murmur in the pulmonary area and a pansystolic murmur sometimes in the tricuspid area. You know all these things now, but then there should be completion in the answer. Okay. Yeah. What are the clinical signs of hepatic hydrothorax? So that's how you look for the other systems here. That is the points we can cover when the patient is supine, and then you need the patient to make the patient sit up, and then cover a few points. That's all.
Yes, sir.
Yeah. What are the clinical signs of hepatic?
In hepatic hydrothorax, sir, on inspection, we may find the trachea to be shifted on the left side because hepatic hydrothorax is mainly on the right, sir. Secondly, on percussion, there will be dullness on the right side, and also there will be reduced air entry, sir.
Who said that? Kushan?
Yes, sir. Kushan, yes, sir. Me, sir.
I think you have well said, that's very good. There's a mediation to the left, and here you can make it out very easily, the apex beat will be shifted, because it is shifted to the left. That one you have covered very well. Okay. Had it been to the right side, it would be more difficult, So that one you have covered very well. It's very good. And then there is a stony dullness on the right side and absent burst sounds. So I think, that's all you will be looking for, So here you should know what to look for, how to look for in the other relevant system examination. Okay, is it okay to you? Is it okay?
Yes, sir.
Yeah. And this patient had evidence of massive right side pleural effusion. Okay?
Yes, sir.
So the pleural study was done. Yeah, Cyril, can you take it up?
The total
Read, please.
is 2.3 grams, albumin is 1.1. Total count is to 550 with a neutrophils of 74, AD of 22 with an albumin of 3.4, sir.
So what is your diagnosis? Sorry.
It's a transudative fluid.
But then?
It's a transudative fluid, sir.
Oh, is it that way you call it, transudative or exudative, or in the context, you would like to take it up differently? Kushan.
Yes, sir. Sir, for this patient, sir, I would also like the pleural fluid LDH level, sir, and the serum protein, sir. So if the serum protein is more than 0.5, the pleural fluid protein is more than 0.5 of the serum protein, then it is likely to be exudative, sir. If it is less than 0.5 and the LDH is less than 0.6 of the serum LDH, then it is more likely to be transudative, sir. According to the
why don't you actually just like in the case of these ascites, why don't you take it as a high sag and a low sag? Because what is the diagnosis here? The diagnosis is what is the diagnosis? Is it tuberculosis, or is it what is the diagnosis?
This is
sir, it is high. High.
It's a high sag low protein ascites.
And the
what's the
ADA is low, sir. So, sir, hepatic hydrothorax.
Yeah, you make the diagnosis of hepatic hydrothorax. Okay. Okay, that should be your diagnosis. Yes, and then you look at the TC, it's a 550. What's the comment on that?
Sir, it can be spontaneous empyema.
Spontaneous bacterial empyema.
Empyema,
Okay.
yes.
Is there any difference here? No. Is there any difference in the cell count, for spontaneous bacterial empyema versus spontaneous bacterial peritonitis? What is the diagnostic criteria for SBP?
Sir, the neutrophil count should be more than 250.
So here?
Sir, here, sir, it is probably more than 300 or 350, sir.
Yeah, so you can make the diagnosis of
spontaneous bacterial empyema, sir.
Sorry, what's your thought on that?
So I'm not sure, sir.
There is a difference there. Okay, in the case of spontaneous bacterial empyema, you need to have a cell count of more than 500 of polymorphs. Okay, if it is less than 500, or more than 250, you need to have the culture positivity. So there is a slight difference here between SBP and spontaneous bacterial empyema. Okay, so further investigation is in fact what you need in fact is a culture here. You can't actually straightforward, you can call it, spontaneous, hepatic hydrothorax, but for the infection element, you need to have a culture also. Okay, the difference is okay. Yeah.
Yes, sir.
How will you treat this patient? So
Sir,
I think I will just skip that. I will just skip that. No, I just skip that. Okay. Now you will go for further investigations here. Okay. Kushan, can you take it up?
Yes, sir. The hemoglobin is 10.5, sir. WBC count is 11,800. The differential polymorph is 70 and the lymphocyte is 28. ESR is 55. Platelet count is 90,000. CRP is 45. HbA1c is 8.8. Creatinine is 1.4. Potassium is 5.4 and sodium is 126.
Okay. Now, what is the renal diagnosis?
Sir, to make the renal diagnosis, baseline creatinine, that's baseline creatinine, sir.
Baseline creatinine. Okay, the baseline creatinine was 1 milligram about 4 months back.
Okay, sir. 1 milligram, 4 months back, sir.
Yeah.
Okay, sir. And
Kushan seems to be having bandwidth issues.
sir, I would like to have a urine routine and the ultrasound to look for the kidney, the hypertension. So she could be having an underlying. Sir? Hello.
Oh, okay. Yeah, ultrasound scan is okay. Normal for the kidneys.
Oh, okay, sir.
Yeah.
So, sir, we can consider it as an acute kidney injury if the urine is also not showing any proteinuria or.
So yeah, acute kidney injury. You can call it an acute kidney injury there.
Yeah.
And now, what's the criteria there?
Sir, the criteria for acute kidney injury that the creatinine should rise by 0.3 or more than 50% of the baseline, or the urine output should be less than 0.5 per kilogram in 24 hours. Sir.
No, yeah, I think your time frame is not correct. An increase by 0.3 in 48 hours.
48 hours, sir. 48, sir.
50% in less than 7 days time. So I think that time frame is very important. Okay.
Right.
Yeah. Well said. Okay. And acute pre-renal, due to diuretics and sepsis, because of that also probably you may be able to make out that it's an acute kidney injury, and the mechanism may be because the patient is taking diuretics, and you have got evidence of sepsis also. Okay.
Yes, sir.
So that is the my answer lies. And the second question, could it be CKD? Okay, and probably, no, I think, well, I have given the answer also there, probably you can just read it then. Okay. I have inadvertently given the answer also there. Okay.
Yes, sir.
Yeah, so I think, it is possible. Okay, I told you the creatine, basal creatine available is 4 months back, and suppose, say about 3 months back, it is about 1 milligram percent, then you can consider it as a CKD also. Plus, the duration criteria plus the one of the other two. Yeah, markers of kidney injury. What are the markers of kidney injury? Well, you try to tell me that, it is albumin, and then probably NGAL also. Okay. Yeah. So how will you manage this kidney problem? A question, you can continue there. You are comfortable. Yeah. Kushan, is it my problem? Your
Yes,
problem?
sir. Protein. Yes, sir.
Yeah.
So, sir, for the yes, sir.
Yeah.
Sir, so for the kidney problem, sir, I will classify the AKI. So it is more likely to be AKI 1B, sir. So this patient will require albumin infusion, sir, at the 1 gram per kilogram albumin infusion, sir, and that has to be given for 48 hours. And if there is no decline with that, and the sepsis has also been treated, and the diuretics have also been stopped, sir, then we can consider it to be hepatorenal syndrome, and in that case, we'll have to add terlipressin, sir.
Okay. So I think that's very good, That answer is very good, satisfying. Okay, so you need to stop diuretics, and then initiate the antibiotics and expand the plasma volume with the albumin. I think you're probably, if there is a urine albumin and NGAL positive, probably, well, you need to have probably consult your nephrologist as well. And the comment on the electrolytes here, Cyril, can you take it up?
So there is hyponatremia and hyperkalemia. It could be drug related.
Okay, yeah. What is the likely cause here? Yeah.
Diuretic induced is a possibility, sir.
Diuretic induced. Okay, which diuretic can produce this?
Spironolactones.
Spironol. So I think, spironolactone induced is a possibility. So he may be getting that. What is the likely cause, if the patient is not on a diuretic for 2 weeks right now?
It could be one other possibility is
it could be dilutional hyponatremia in case of chronic liver disease. Secondly, there could be adrenal insufficiency that can cause hyponatremia and hyperkalemia, sir.
Yeah, I think that's a very good answer, So there can be a relative adrenal insufficiency, That may be the reason. Okay, that's well said. Okay, you scored a point there. And suppose the potassium here is 3.2. What is your diagnosis? Sir, can you continue, please? Is it Cyril?
Still, sir, I will possibility of diuresis or diuresis if there is a loop diuretic.
Yeah, loop diuretic. Yeah, very good. Yeah.
Also possibility of sepsis in view of hyponatremia. I will rule out sepsis or any infectious.
You mean sepsis can produce hypokalemia?
Well, there was
hyponatremia. Hyponatremia is okay, because of dilution hyponatremia because of the stage of the liver disease. Yes, but the problem is potassium. Both are low.
Sir, I would also think of sir, loop diuretic as the first option, sir.
Yeah. Sure. Okay. So I think, there are other options also. Probably you need to think in terms of intrinsic kidney problem, like interstitial nephritis, for if the patient is on NSAIDs, can produce that, You said sepsis. Sepsis is also a correct answer. Sepsis can also produce interstitial nephritis, and hypothyroidism. If the patient has got a hypothyroidism, so always look for that, you can produce both, lower levels. And if the patient is taking lactulose overdose and more diarrhea, they can also produce that. Okay. So in the relevant situation, you need to probably, if you give the complete answer, it'll be okay. Will you stop beta blocker here?
Yes, sir.
Kushan.
Yes, sir. Yes, I will.
Yeah.
I will stop beta blocker in the presence of acute kidney injury, sir.
Okay. So I think even probably you can go for the stopping course. In what all situations in cirrhosis liver, you will stop beta blocker.
Sir,
There are
if
other
there is a
stopping courses.
sir, if there is a refractory ascites, if there is a spontaneous bacterial peritonitis, if there is acute kidney injury, and hepatic encephalopathy also it can be with it.
Definite indication.
So I think there are some stopping rules. The beta blockers may be good. It actually increases the longevity in cirrhosis liver definitely. But then you need to stop it. You said probably MAP you need to consider. Then sodium is less than 120. And AKI and SBP you said, refractory ascites also you said. Okay, so there are stopping rules. In these conditions, I expect completion. Okay, completion of the answer. So what is the prognosis like? First, we made the prognosis that, we thought the patient has got stage 3, and we prognosticated that her mean survival could be about 30 months.
Yes, sir.
Yeah. Now, would you need to re-prognosticate the patient? Who is answering?
Yes, sir.
Who is answering?
Sir, me, sir, Kushan, sir.
Kushan. Yeah, Kushan. Yeah.
Yes, sir. Sir, in the presence of acute, sir, in the presence of acute kidney injury, and also in the presence of if she has spontaneous bacterial empyema, sir, then her, 2-year survival is itself around 50%, sir. So
2-year survival. Yeah. So I think the sepsis, but more importantly is hepatic hydrothorax. Ascites is okay, but then hepatic hydrothorax will seriously reduce your longevity. Okay. With the hepatic hydrothorax, so I think hepatic hydrothorax is very, very, very serious affair. It reduces your longevity to a mean longevity maybe around 8 months. That's all. And that's why you get a priority for transplantation also. Hepatic hydrothorax. Okay. So I think with the diagnosis of hepatic hydrothorax, her longevity has actually come down, dropped tremendously. Okay?
yes, sir.
Yeah. And now, how will you treat her hepatic hydrothorax? If you treat it properly, can you bring back that longevity? That's the question. In the case of ascites, I said, if you make the patient ascites free, the prognosis will not change. But here, if you can bring it back, will it reduce probably the reverse of prognosis here? Okay, so then yes, you can answer later, But now you can tell me how you treat this hepatic hydrothorax.
Yes,
first from
sir.
Question,
Yes, sir. Sir, we can continue with the diuretic, sir, once the AKI has been resolved. And secondly, sir, therapeutic thoracocentesis can be done to reduce the symptomatic dyspnea. If it is not responding to medical therapy, in that case, we can consider TIPS. And sir, if the patient is
that's my comment here. Diuretics will be ineffective and contraindicated, for here. You can see the creatinine level is going up, acute kidney injury and all. And paracentesis, there's a very frequent reaccumulation. Unlike in the case of, the ascites, you need to do a lot more frequent paracentesis, thoracocentesis here. Probably, even twice a week you need to do. For how long will you do? Okay, so that will not be the answer here. So I think we need to go for something definitely.
TIPS can be considered, sir. TIPS.
Yeah. So if you do TIPS, will you be able to reverse the prognosis?
Prognosis does.
Yes.
Pardon? For example,
there is a survival advantage, sir.
There is survival advantage
for the survival, sir.
For TIPS. Okay.
Yeah.
And
Yes.
then Cyril, I want to hear the opinion of Cyril also.
So for with transplantation, you have a survival benefit. But TIPS, there is no survival benefits.
Yeah. I think the point is that, if you select your patients properly with the chips, there is survival advantage. You will be able to reverse the prognosis. Okay, otherwise you need to go for transplantation. So that is very important. So here you need to find out, whether this will reverse the prognosis, whether the patient will be having survival advantage. In which case you need to go for tips. Okay. So I think probably I'll not be able to ask that question, because you don't know the point, but I think, well, that's why we have done all this very, very painstakingly. We have discussed, the patient said, if the patient is still in child B status, if the male is going to be less than 20, the platelet count is going to be more than 70,000. If the bilirubin level is low, it has got a survival advantage. Okay, so this it will improve the kidney function. It reduces the variceal burden of the possibility, but then slightly it actually worsens hepatic encephalopathy. So if the patient has got hepatic encephalopathy, probably you'll not be able to go for it. So do we think this patient is candidate for TIPS?
Yes, sir. She is a candidate for TIPS, sir, because she is child B status. Platelet count is also more than 70,000, and bilirubin is less than 5, sir.
Yeah. So I think she is an ideal candidate for TIPS, And this patient underwent TIPS, and the pleural effusion, the sites both disappeared, and currently the patient is diuretic free, and the kidney function is actually normalized. Okay, so I think with that I'll wind up here, and then we will. So I think, both you have done well, Kushan and Cyril have done well, but the problem here is that, here, well, the most of the questions are actually straightforward, and we expect complete answer and the correct answer. Okay, so that is the problem. So I think the first case, well, we could accept quite a lot of, the laconic gaps. I could, probably accept. And the second case, well, I think less chance for errors. So I think that's how I have actually given you two contrasting cases and my comments. I think both you have done very well, and then both are exam going.
Yes, sir.
Yeah, so I wish you good luck for both of you, and then we will wait for the comments of Professor Vagisams and Professor Jayanti.
Andy, ma'am.
Very nice cases, both the cases very well done. I think students were also quite competent enough to answer most of the questions.
Yeah, thank you, ma'am.
Yeah,
they're very good. They're very good students.
Yeah, and other quite confident also in answering. The other thing was I was asking other systems. I think few other things that just to recall. Don't miss an MHE in these patients. You see that into a detailed CNS examination. You must know all the tests for MHE. And a lead from portopulmonary and hepatopulmonary syndrome would also be cirrhotic cardiomyopathy. So that's a totally different entity altogether. So the discussion will move not only to the right side of the heart, but you also have to focus yourself on the left side. So these were some of the things that I think, two other things that should have been discussed, and these can be questioned, not discussed. These are the other questions that can be asked as a takeoff. As you keep doing well, all these other questions will start coming up. And then I think a BMI is also high. So what will you do for a weight reduction? I think that's something that you have to discuss. And of course, the management of diabetes, control of hypertension, and the discussion will also go towards NAFLD, MAFLD, and the drugs and medications that you will resort for reduction of a weight in the management, apart from specific management of the primary problem that the patient has now. And being a diabetic and hypertensive, I think primary renal pathology must also be kept in mind because it's quite a long duration of illness. Well done, both of you. Good. Wish you all the best. Yeah.
Thank you.
My comments are, there's an extremely very high chance of having a liver disease patient kept in the examination, because that is what you see in and out. The most common case of GI problem in the inpatient is actually cirrhosis of liver. Okay, so all the residents are expected to know everything about cirrhosis of the liver, and that's why Professor Vinay Kumar was repeatedly telling, you have to answer all questions because cirrhosis is considered as a very common problem. Even MBBS doctors are able to diagnose and manage most of the issues. Okay, so we cannot make mistakes. We are supposed to be specializing 2 levels above general practitioners. So we cannot make any mistakes in the diagnosis or day-to-day management of cirrhosis of the liver. And don't be too happy when you get a cirrhosis of the liver. If you get cirrhosis of liver, that means you must be expecting lot of questions, and examiners will get really cut up if you are not able to give common answers to common questions. Professor Vinay Kumar was repeatedly telling common questions, easy questions. No, cirrhosis is a very common problem, so you have to read thoroughly about cirrhosis liver, everything, percentages, survival, what happens when there is SPP, what happens when there is GA what happens when there is renal failure. No, the prognosis differs for each of these conditions. I think it has been well covered by Professor Vinay Kumar, and it's a very good case discussion. I appreciate. Do we have any other faculty today? Ma'am, any idea as to when the practical exam would be?
Nothing, because the results are not yet declared of the people who appeared for the additional exam. It will get postponed, and now only 50% will be working in the center. We have no idea at all.
So it is unlikely to be next month.
It will definitely be not this month.
Okay. Even next month is doubtful. Usually there is a delay of more than a month after publishing the theory results, no?
But here, given the results of the additional students that appeared has not yet been declared as yet. That has to be declared, and then they have to decide whether it's OSCE. I'm sure it will not be a live session. It will continue to be a virtual.
This time also it will be more of a virtual OSCE style.
Wait for 1 or 2 months till the downfall of the COVID.
So in such scenario, what Professor Vinay Kumar taught today, it will be highly relevant.
Yeah.
Instead of a long case discussion, the classic discussion, it's more likely to be an OSCE style. At any point, questions can be asked.
The same like case can go as a long case, the same case. With all the questions that he's asked, the same case will go on. They will go on to cirrhotic cardiomyopathy, MHE, NAFLD, management, and the same case can go on for 1 hour as well. So I think they should be able to fit in both OSCE versus as a short case. Now they don't have long cases. I think it's 4 short cases. It's 4 short, and the first case comes as long. That's all.
Yeah, first case automatically becomes a long case, and then.
It's 4 short.
So that means short will be OSCE style or the
usual. Short will be like OSCE. Yeah. 4 short will be like OSCE. This is the typical OSCE. It's a typical short case. Exactly half an hour sir has taken, and that's the way it is. Yeah.
Okay. I think as there are, ma'am, any simple reference to calculate daily calorie and proteins of diet of patient, any simple method by which you can calculate the calorie requirement and
asked with the dietitian. They are the ones who tell us exactly the calculation and the requirement, and also there's an Indian data. There's a reference from our own Indian subcontinent where they've given us publications on the calorie requirement and what substitutions can be given for each of them. Probably I can share it with VT and then we can pass it on to them.
Okay. Because the first case was an eating disorder and there is a lot of nutritional problem, the caloric intake, the type of food she is taking, what you have to advise as part of treatment, everything is very important. So I think gastroenterology students should have good knowledge about nutrition as well.
Including the second case.
Okay, we don't have any further questions or comments.
Thank you, Kumar, sir. Thank you so much, sir. Nice.
So thank you very much.
We look forward.
Thank you for being. Yeah. Nice to be with you, seeing all of you. So thank you very much.
On behalf of ISGK, I want to thank you from the bottom of